Head injury. One of the important subjects in a CNS pathology is the head injury. There are two main divisions of the brain, cerebrum and cerebellum, are quite distinct in structures. There is absence of the lymphatic drainage in the brain. There are two types of tissue in the nervous system, according to the embryological origin. Neuroectodermal tissues include nerves, neuroglial cell, and together forming of the predominant constituent of the CNS. Mesodermal tissues include microglial, dura mater, leptomeninges, pyoarachnoid, blood vessels, and their accompanied mesenchymal cell. One of the important constituents of the nervous system is the neuron. It is a highly specialized permanent cell of the body, which is incapable of the divisions after the first few weeks of the birth. This brain damage involving the neuron is irreversible. As mentioned previously, injury into the tissues has a response by repair. We have two types of repair: repair by regeneration and repair by a fibrous tissue, according to the type of tissue. And we classify the tissue into the sustained cell, labile cell, and permanent cell. The CNS cell is a permanent cell. When it's injured, regenerations occur by fibrous tissue regenerations. Neural response into the injury. There is a variety of the way depending on etiological agents, pathogenic process, central chromatolysis, atrophic chain degenerative, axonal injury, intraneural storage substance. In general, disease affecting the CNS we classify into degenerative disease, inflammatory, neoplastic, and traumatic. This is a normal appearance of CNS cells, astrocytes, with a predominant process. Oligodendrocyte, look into the body of oligodendrocyte on axon. Microglial cell, ependymal cell. This microscopical picture, astrocyte with their process, oligodendrocyte with rounded body, with rounded nucleus. Ependymal cell with a hairy surface. Cluster of microglial cell. Microglial cell is a type of reticuloendothelial system. It is a type of tissue macrophage. Cellular reactions, we have a neuronal and glial. In neuron, one of the most important prominent tissues response is the red neuron. This is the name of the red neuron due to the appearance of red hue under the examinations or under the microscope. Karyolysis, subacute or chronic cellular loss, gliosis. We have a reactive gliosis. Axonal response, presence of inclusion body. This inclusion body is different according to the causal agents, either lipid inclusions, protein inclusions, carbohydrate, or viral inclusion. Glial reactions, we have a gliosis, which in short is swelling of glial cell and fiber, or presence of inclusion body can be seen. Degenerations refer into the neural death. Degenerations is a degradation of the neural cell or a death of the neural cell. It is occur as a result of a progressive disease process. Some of durations are seen in certain slow involved neurological disease as Kuro disease, characteristic histological features by a cell loss. Reactive gliosis, in long-standing gliosis, the cytoplasmic reactions, astrocyte shrinkage in size, and cellular process become more tightly interweaving, what is called fibrillary astrocytosis, which is a characteristic feature of astrocyte reactions. Axonal reactions and central chromatolysis. Rounding of a cell body with a blobbing appearance, displacement of the nucleus into periphery, dispersions of the chromatin to periphery. In neural inclusions body, One of the important subjects is the presence of inclusions bodies that may be diagnostic for the causative agent of this pathological process. Inclusions bodies may be vary according to the etiological agents, maybe lipid, protein, other inclusions. One of important inclusions bodies is a viral inclusions bodies. In general, the presence of the neural inclusions bodies is manifested of damage, aging process, genetic disease, viral infections, lead into the presence of abnormal intranuclear or intracytoplasmic inclusions bodies. As seen in herpetic infections, cow dry bodies, cytoplasmic inclusions bodies as seen in rabies, Nigra bodies, or both in the nucleus and cytoplasmic in cytomegalovirus infection. This is a microscopical picture of a red neuron. The red hue appearance can be seen obviously. The change occur in response into the hypoxia, as we are mentioned. There is shrinkage in the neuron, pycnosis, condensations of the chromatin, loss of the Nusselt's substance with intense cytoplasmic eosinophilia. This is an red hue appearance. It's called a red neuron. Chromatolysis, manifested as a swelling of the nerve, blobby appearance, Nussel migrations into periphery, pale cytoplasmic appearance or hue, a nucleus moving into a periphery. Gliosis. As we are mentioned, the gliosis is the most important histological indicator of CNS injury, regardless its etiology. A gliosis is an reactive response of the glia, or whatever its type, and characteristic by both hypertrophy and hypereplasia, as a type of an adaptive body response into the injurious stimuli. In this reaction, the nuclei of astrocytes, which are typically rounded to oval with eventually disturbed pale chromatin, enlarge become vesicular nucleus with development of the prominent nucleoli. Glial reactions, a previously scanned cytoplasm expand into the bright pink appearance, somewhat irregular swath around the eccentric located in nucleus, from which emerging a numerous ramifying process. This called gametocystic astrocyte. The gametocyte is come from the Greek name as a gametes, is a blobby appearance, a large buffy appearance. Long-standing gliosis, cytoplasmic of the reactive astrocyte, shrinkage in size and cellular process is become more tightly interweaving, giving what is called a fibrillary reactions, which is a characteristic reactions. This is the macroscopical pictures of the gliosis near a metastatic carcinoma. Look into the vesicular nucleus, blobby cytoplasm, and the view in the below show a white matter with a reactive astrocytosis, as denoted in a row. Here we can see that the reactive astrocyte is abundant eosinophilic, pink cytoplasm. Sometimes cells like these are termed gametocytic cells. As I mentioned, it's from the Greek name, mean a plump, buffy, enlarged gametocytic cell. Another patterns of the neuronal injury: acute hypoxic ischemic red neuron in cerebral cortex, with individual cell bodies are shrinkage along with the nucleoli, prominent stain by eosinophil. Second one, axonal spheroid, visible axonal reactions, mostly in the middle of the view. More than one reactions can be seen at the point of disturbance or altered axonal transports. The view C, axonal injury seen can be swallowed with the cell body, with peripheral dispersions of the Nussel substance and the nucleus. This is what is called a chromatolysis. Rosenthal fiber. It is a characteristic fiber denoted by the presence of thick, elongated, brightly eosinophilic, somewhat irregular substance that occur within astrocytosis of long-standing gliosis and pericytic astrocytoma. Interweaving of the process giving a fiber-like appearance is called Rosenthal fiber. Oligodendrocytic reaction or oligodendroglial reactions, injury and loss in demyelinations disorder and in leukodystrophies. Oligodendroglial nuclei may be harbor viral inclusions in the progress, multifocal leukoencephalopathy. Reactions into the ependymal cells when injury occurs, subependymal astrocyte proliferations to produce a small irregularity in the ventricular surface, ependymal granulation. Reactions of microglial cell. As we know that the microglial cells is a type of reticuloendothelial system. It is a tissue resident macrophage. Their reactions denoted by the proliferation, development with elongated nuclei, rope cell, as in the neurosyphilis, forming of aggregated cells but small foci of tissue necrosis, what is called or denoted by microglial nodule, congregations around the cell body of the dying neuron in neurophagia. Microglial cells, type of the macrophage, and one of their functions is a scavenger cells. So the phagocytosis of the dead material, as it's in the nervous system, it's called a neurophagia. This is an example of the neurophagia. Macrophage encircle the degenerative neuron. One of important medical emergency subjects is a CNS trauma. In general, by definitions of trauma, CNS trauma is a blow to the head, may be penetrated or blunt. It can be occur open or closed injury. It may be associated with skull fracture, parenchymal injury, traumatic vascular injury with a sequelae, and we have another type, we have a spinal cord trauma and a spinal cord injury. A trauma into the head, either closed trauma, penetrated, associated with hemorrhage, contusions, lacerations. There are many of you seen presence of penetrated tumor, blunted tumor, hemorrhage, intracerebral hemorrhage, skull fractures. The fractures of the skull, as any fractures in the body, may be open, closed, linear, communicated, diastatic, depressed from focal below, and basilar. Mostly the basilar fracture associated with rhinorrhea. Basal fractures, if there is a cribriform plate fractures, may associated with rhinorrhea. Petrous body fractures, either longitudinal fractures or a transverse fracture. Cerebral contusions lesion. It's resemble into the or analog into the bruising in any parts of the body or in soft tissue, associated with direct parenchymal injury of the brain, caused by rapid tissue displacement, disturbance of vascular canal, and subsequent hemorrhage, head injury, and edema. Since they are closest to the skull, the crest of the gyrus are the part of the brain that are mostly susceptible into the traumatic injury. Anybody, when there is a direct trauma on this part of the body, lead into formations of the bruising. In the CNS, a direct parenchymal injury may associated with the bruising in the cerebral tissues and what is called contusion. Diffuse axonal injury. One of the important subjects may associated with the severe injury or a transient amnesia or sometimes a minor injury. It's usually associated with accelerations, decelerations. Injury is the most common cause of post-traumatic dementia, resulted from sudden angulations, decelerations, acceleration. The hallmark of a severe traumatic brain injury is the presence of accelerations, decelerations, differentiations in the movement adjacent into the regions of the brain, lead into the compressions, elongations, twisting into the axons. This may associate with transient injury, may associated with lacerations and sheared axonal injury, or stretching axon, twisting of. Diffuse axonal injury is the major cause of the prolonged coma after a brain injury, probably due to the distortions of ascending reticular connections to the cortex. Angulations force, this is leads into an oblique twisting with a sagittal forces. A short axonal retractions and are event histologically at retractions ball. The presence of the axons like a ball with accumulations of the body with elongated of the process located prominence near the angle of lateral ventricle and in the brain stem. Contusion. One of important subjects. It is a clinical syndrome resulted from biochemical alternations in a substituent of the brain. Alternations in consciousness secondary into the head injury resulted from the change in the momentary of the head, a transient loss of the consciousness with widespread paralysis, sometimes seizure following of the recovery by hour or 2 days, although the neurological recovery complete. Amnesia for the event is persistent. Pathology is unknown. Biochemical change and physiological change blamed to be behind this type of injury. Laceration. If there is a penetration into the brain by a projectile as a bullet, skull fractures, fragments of the bone from the fractures lead into the tearing, vascular discernment, hemorrhage, injury along with linear path. One of important pathological process is herniations. May occur as a primary pathology or secondary into the other pathology such as increased intracranial pressure. Herniations of the brain parenchymal happen into 3 sets. Subfalcian herniation, when there is unilateral or asymmetrical expansions of cerebral hemisphere displaced into the uncingulate gyrus, is displaced under the falx cerebri. Tonsillar herniations refer to displacement of the cerebellar tonsil through foramen magnum. This pattern of herniations is life-threatening because it can cause into the brainstem compressions and compressions into the vital respiratory center and cardiac center into the medulla oblongata. Third type of herniations, we have transtentorial herniations. It is occur when the medial aspect of the temporal lobe is compressed against in the free margins of tentorium. This may lead into the compressions of third cranial nerve, lead into the pupillary dilatations, ipsilateral, compressions of posterior cerebral artery, ischemia of the visual cortex, and compressions of cerebral pendiculate, ipsilateral hemiparesis, and Kernohan's notch. Durate hemorrhage, flame-like shape in the secondary in the brainstem hemorrhage, linear flame-like shape, usually occur in the midline and paramedian regions, in the bones and in the midbrain. This is a type of herniations, subfalcial herniations, transtentorial herniations, and tonsillar herniation. This is a gross pictures, and the midbrain show a flame-like durate hemorrhage. A durate hemorrhage. This type of many type of hemorrhage, we have an intracerebellar mass lesions lead into the compressions where herniations in the parts of the brain associated with the durate hemorrhage, projection through tentorial cerebri with ankle herniations. Hematomas or hemorrhage, we have epidural hematoma, subdural hematoma, subarachnoid, intraparenchymal hematoma, interventricular hematoma. We are explain it in detail, everyone. Epidural hematoma, transections of the middle meningeal artery between the dura mater and squamous portions of the temporal bone. It is appearance as lens-shaped accumulations of the fresh blood that stop at the coronal suture line. An epidural hematoma may expand and may lead into it is a medical emergency, a neurosurgical emergency required and prompted drainage. When it's removed rapidly, may lead into the improvement of the life of the person. If left, may associated with death. Peak incidence in second decade of life, source from vessels that run in the dura, middle meningeal artery from the skull. Clinical features according to the size, shape, and rate of accumulations, mostly associated with loss of consciousness, transient loss of consciousness, and recovery of consciousness, lucid, intervenal, and non-specific, confusions, lethargy, agitations in some instances, focal neurological deficits. This is an appearance of epidural hematoma associated with the trauma in the skull with meningeal artery lacerations, hemorrhage that compress the underlying brain tissues, and associated with an increase in intracranial pressure. This is a scheme show an epidural hematoma in the left associated with the lacerations of middle meningeal artery. Look into the lens-shaped appearance of epidural hematoma that denoted by sagittal margin, and subdural hematoma in the right. It occurs below the dura mater, not limited by the meningeal attachment into the bone. Associated with the compressions of underlying brain tissues. Middle meningeal artery lacerations associated with epidural hematoma. In the right, presence of multiple trauma with midbrain durate hemorrhage, compressions of underlying tissue may associated with herniations. These complications may be occur in associated with the fractures of the skull and epidural hematomas. Subdural hematomas caused by dissection of the bridging nerve crossing the surface of the brain into the dura sinus. Acute one associated with a clear history of the trauma, unilateral, bilateral, mostly in infants. There are a certain clotted blood in the frontoparietal lesions, and the lining brain is flattened and subarachnoid space is clear. Typically, venous bleeding itself limited, and breakdown organizations of the hematoma take place at time. Commonly in old age group and infants when there is weakness in the blood vessels and blood vessel support, causing a high vascularity impact with a child abuse followed from significant height trauma, especially in old age, associated with a cerebral contusion. Sources: cortical bridging venous and dural venous sinus. Within 24 hours after injury, lateral aspect of the cerebral hemisphere is affected. This is a scheme show the presence of subdural hematoma, denoted the presence of the hematoma below the dura, associated with the compressions of underlying cerebral tissues. Large organized subdural hematoma as in a gross appearance attached into the durate coronal sections of the brain show the compressions of the hemisphere underlining the hematoma. When the hematomas has been removed. Chronic subdural hematoma with a multiple episode of rebleeding, loss of the common associated with trauma and associated with the brain atrophy. Subarachnoid and intraparenchymal hemorrhage most often occur concomitantly in the setting of the brain trauma with superficial contusions and laceration. Also, we have in CNS trauma sequelae may associated with hydrocephalus, may associated with dementia, chronic boxer encephalopathy, diffuse axonal injury associated with white matter injury. Hydrocephalus refer as accumulations of excessive CSF within the ventricular system. Accumulations is arising from one or two processes: overproductions or failure of drainage. Failure of CSF regress from a cranial valve, which is the most common mechanism. Obstructions, non-communicating hydrocephalus. Communicating hydrocephalus, when obstructions is occur outside the ventricular system, may be complicated subarachnoid hematoma, inflammations, and arachnoid scarring. Non-communicating, only portions of the ventricular system is enlarged, not bilateral, because of the excessive of not communicated. Excessive CSF is maybe occur because of the mass in the third ventricle. Communicating enlargement of entire ventricular system. Hydrocephalus versus vacuum refer dilatations of ventricular system with of compensatory increase in CSF volume secondary to the loss of the brain parenchyma. This is a picture appearance of hydrocephalus, dilated lateral ventricular seen in the coronal sections through the mid-thalamus. Look to the dilatations of the space. Hydrocephalus with horizontal sections of the brain, dilatations of ventricular space. Cerebral edema. In general, edema increase a water constituent. Cerebral edema, an increase of the water constituent within the brain parenchyma. We have two principal types recognized to the cause of or blamed to be the cause of edema in the cerebrum. Vasogenic edema, localized or generalized, the most common cause of edema. And cytogenic. Cytogenic may associated with inflammations mostly and sometimes with intoxications. Cytogenic is either localized or generalized, also vasogenic localized or generalized. A combination of cytogenic and vasogenic edema is common in infections. Interstitial edema, while cytotoxic and vasogenic edema appear as hydroping edematous, increase of the brain tissue mass softer than normal, and often appear as overfilled of the cranial vault. In generalized edema, the gyrus are flated and intervening sulcus are narrowed and ventricular cavities are compressed. As the brain expands, herniations may be occur and is secondary to the increase intracranial. This is an example of the cross pictures in the brain edema. Cerebral edema leads into the anaphylaxis of the gyrus. Spinal cord injury. One of important subject is the spinal cord injury. Parallel into the brain patterns of injury or cerebral basis, and usually secondary to the spinal column displacement, fractures, level of injury, mirror motor loss. Each part has been injured. The nerve affecting will be appears either in cutaneous or in the motor nerve involvement as a mirror image in each of a level C1, C2, C3, and each one has been affected. The clinical sign and symptoms differ according to the level has been affected. Thank you for your listen.